Your Excellency, representative of WHO to Thailand, JICA, Better Health Project under the Prosperity Fund, UK, ASEAN Institute for Health Development, Mahidol University, and the International Federation of Medical Student Association, Thailand. Good morning and welcome to the Prince Mahidol Award Program Conference 2020 with a side meeting on the topic of investing in the health workforce toward the universal health coverage in SDGs, a community-based approach. My name is Supatida Jemsawat from IFMSA Thailand, Faculty of Medicine, Thammasat University.
And my name is Jatutanai Sowikamin from IFMSA Thailand, Faculty of Medicine, Chulalongkorn University. It is our honor to be your moderator for the session this morning.
Please allow me first to foremost inform you this morning program. First part of the meeting will be the remarkable presentation from 7 of our speakers, followed by a break before entering a commentary by Dr. Suwit Vibun Prasert, and lastly finished by the question and answer session along with the take-home summary from our speakers.
I would like to take this opportunity to start our section of today. Please allow us to introduce Professor Dr. Wanicha Chuenkongkaew, Professor of Ophthalmology, Silila Hospital, Faculty of Medicine, Mahidol University, who is also a regional coordinator of Asia Pacific Network on Health Professional Education Reforms. Ladies and gentlemen, please join me to welcome Professor Wanicha Chuenkongkaew.
Good morning, hello everyone. We are honored to have our 7 speakers here, including me. Professor Neil, you know him very well. We will introduce him later. Dr. Daniel from WHO, Dr. Aiga from JICA, Dr. Pudit from Mahidol University, and Cynthia from Hong Kong, and also Fa from Thailand. So, most importantly, your participation will be very highly appreciated, and we need your perspective to share on this session. Thank you.
Thank you so much, Professor Dr. Wanicha, for your opening session. Without further ado, I would like to take this opportunity to start our first presentation. The first speaker of today is Professor Dr. Neil Squires. Professor Dr. Neil Squires is the Director of Global Health, Public Health, England. He is working with the Better Health Program under Prosperity Fund, United Kingdom Government. He was the Head of Profession for Health at the Department for International Development, with his long career working internationally. Professor Dr. Neil is going to talk about the topic of United Kingdom experience in preparing health workforce to serve future population. Ladies and gentlemen, please welcome Professor Dr. Neil Squires. The floor is yours.
Thank you very much, and it's a pleasure to be here. And I've already attended a fascinating day of presentations yesterday, which demonstrates how rich the PMAC conference is in terms of sharing experience. And I think one of our main reasons for being here is to learn from one another, because every health system faces different challenges, and I think we have an awful lot to learn from different approaches and different contexts. So I'm just going to very briefly highlight the UK context. I mean, the UK National Health Service is one of the oldest universal health coverage systems in the world, established in 1948, and it is now the pride and joy of British people, and that's a great place for the health service to be. Everybody wants it, everybody fights over it, it's a political priority in election campaigns, and yet it's also one of those issues where it's increasingly difficult to maintain the levels of services that meet people's ever-increasing expectations. So the moment you create a service that has such high levels of popularity, then you create a political problem for yourselves, which needs to be addressed by constant investment. And we do invest massively. So for a population of 60 million people, the UK spends £197 billion every year on their health service. The health service is the largest employer. 1.24 million people work for the health service, and 1.61 million people work for the social care service. So health and social care, between them, have a massive workforce. But that also is a workforce that we're short of. We're short of nurses, about 40,000. We're short of over 100,000 social care workers. We're short of general practitioners, and we have distribution challenges in where health workers work. So this is a major problem. We have a number of different issues in terms of challenge, or where people, or the challenges that face the system. We have an ageing population. And one of our biggest challenges is that we've medicalised death. Increasingly, the expenditures that are linked to the health service occur in the latter 6 months of life. We spend, on average, £2,900 per person per year in the UK. The costs are lowest from about 11 to sort of 40, but after that, the costs start escalating, rising quickly. Even from the age of 65 to 67, they're still only sort of £2,700 per person per year. But after that, they rise to sort of £10,000 per person per year for over 85. So you can see that the costs increase. So many countries in this region face an ageing population. At the moment, you're able, perhaps, to meet the needs of your populations, but as your populations age, you're going to face huge challenges meeting those needs. With rising expectations and the rising costs of service provision, these add additional burdens to the services that you need to be able to provide to your populations. So this presents a major challenge for universal health coverage. So training and retaining people to meet those needs is a significant challenge. I attended an excellent session organised by JICA yesterday, which focused on ageing, and I heard from Mexico and Chile, particularly in those areas, about the extent to which the communities actively engage in the provision of population health. In many high-income countries, we've lost the value that the communities and families bring. With nuclear families, we don't get the support, so we've actually contracted out the care of our elderly to other people, to the social services. And that in itself is hugely expensive. It leads to increasing loneliness. And so there are many challenges linked to urbanisation and the destruction of communities and community values that we need to look to other countries to see how to recover some of those important values that are less in the community. And my final point really is I attended another session yesterday which was on the importance of health promotion for achieving universal health coverage. And one of the recommendations for that is that we need to ensure that the Ottawa Charter is implemented in full. We don't just need to focus on the reorientation of health services to meet the needs of these ageing populations, but we do need to look at healthy public policy, building healthy environments that enable older people to live longer. And we need to look at enabling society to support the health and well-being of individuals. So these are some of the major challenges which compound this problem of ensuring that we have a strong community-based approach to dealing with the challenge of universal health coverage.
Thank you to Professor Dr. Neil Squires for a remarkable keynote speech on the sharing of methodology to overcome challenge and also on the investment on health promotion. Now, please allow us to introduce the second speaker, Dr. Daniel. Dr. Daniel is a medical doctor specialized in internal medicine and infectious disease. He holds a master's degree in epidemiology from the London School of Hygiene and Tropical Medicine and is a fellow of the Royal College of Physicians and Surgeons of Canada. Dr. Daniel has been working with the World Health Organization since 1997. His work involved developing health workforce in different parts of the world, such as ASEAN and African countries. Please put your hands together and welcome Dr. Daniel.
Thanks for putting your hands together. I appreciate that. My name is Daniel Kertesz. I'm the WHO representative in Thailand. And actually, I'm not really an expert on human resources for health or health workforce, but I've been a WHO representative for many years, about 15 years, in about 6 or 7 countries. So I understand the implications of the challenges in health workforce and the importance of addressing some of these challenges. I'd just like to talk for a second, maybe a little bit about the global context. I think Neil mentioned some of the interesting challenges in the UK. I think these are challenges that we see consistently in the global context. The world is changing. UHC is the target, but we have there are a myriad number of challenges that we currently face. Globalization, industrialization, migration, climate change, urbanization, all of these things face us. We know that the burden of NCDs is increasing. We expect it to increase from 40% to 60% to 2015. Many more people living in urban settings, and of course the challenge of an aging population. The primary healthcare approach remains the gold standard. That's our strategy. It was reviewed in 2018 in Astana. But we have to sort of reevaluate the strategy through what we call a 21st century lens. There's ways that we thought about PHC in the past, and now we have a slightly different optic going forward, looking to the future. And I think there are some important differences, and I've listed them there. But I think one of the most important for me, based on my experience in the field, is that the focus is no longer just on access to services, but it's on quality of service. So you must not only have access to health services, access to health professionals, but they must be of quality. So the health workforce is going to have to adapt to this 21st century context. And I think I've listed some of the things that are going to be necessary, and I think this can form the basis of our discussion going forward. Health workforce density has improved in Sierra countries, but more health workers are needed to 2030. I think the recommendation currently, the index is 44.5 per 10,000 health workers, and we can see that in the Southeast Asia region, only Maldives and DPRK have achieved that number. So, I mean, Thailand is close, but if this is a target or if this is some sort of guidance for us, we see that we've still got work to do in the Southeast Asia region. One of the most transformational notions, again, I think, is on the issue of quality. And I think when we talk about quality, we need to talk about evidence. And I think one of the really interesting thing that's happening in discussions around health workforce is emerging evidence and the use of evidence to make decisions. And I think I've just shown an example here, but there's a lot of evidence now that there wasn't even a few years ago on community health workers, and very strong evidence to support selection, remuneration, contracting of community health workers, as well as evidence to support engagement of the community. So we're continuously using evidence to build up policy arguments for interventions such as community health workers. And again, we can talk about these during the discussion. The other thing is continuing professional education. Lots of evidence emerging that continuing professional education improves both clinical performance and patient outcomes. I have to do continuing professional education. I'm sure most of you in this room, if you belong to professional studies, have to do it. And I think there's really good evidence now that, especially for clinicians, nurses, doctors, that this is an important thing. And again, this highlights the importance of evidence. I just wanted to take a little bit of a turn just to say that, to talk a little bit about investment. Last couple of months ago, I presented at an ASEAN high-level summit on human capital development. It was really interesting. They talked a lot about the importance of a health workforce. What they didn't talk about that I think is really interesting is that what we're learning is that investing in the health workforce is not only good for health, it's great for economies. It's a good investment. It's a good general economic investment. And I think that increasingly more regional, multinational fora, such as the African Union, G20, G7, are promoting universal health coverage at a high political level. And an important, critical component of that these fora are recognizing is the health workforce is a sine qua non. And investing in health workforce is a sine qua non for achieving these objectives. Okay, so this is really critical, and it's being recognized around the world. I think this slide shows only that the amounts, in order to overcome the projected shortfalls, and I believe the number is something around 18 million. If we go according to current trends, by 2030 we'll have a shortfall of about 18 million health workers. The biggest investment we're going to have to make in universal health coverage is investing in our health workforce, and that's that big orange bar there. It's going to be a big investment. I think to reinforce the point that I made earlier, Joseph Stiglitz, who I believe was on the high-level commission on health, employment, and economic growth, really made it very clear that investment in education and job creation in the health sector will make critical positive contributions to economic growth. So not just improvements in health outcomes, but economic growth in general. And I think this commission did really important work in mapping out the clear path from health workforce investment to inclusive economic growth. One of the statistics that stands out in my mind is the return on investment in health, including the health workforce, are expected to be about 9 to 1. So if that's a case we have to make to our policymakers, that it's a really important thing to invest in health workforce. This is the last slide. I think that regional blocks are now, and again from a global perspective, regional blocks are starting to take note of this and take action. Recently, West African countries adopted sub-regional action plan for investing in the health workforce with a goal of creating 40,000 jobs in the health sector by 2022. I spent most of my career in Africa. This is something that is, I think, a tremendous advance. The recognition of the importance of the health workforce, not only to health outcomes, but to economic growth by forums such as these is a really critical advance, and I think something that we need to push this agenda forward. So thanks very much.
Thank you so much for the valuable presentation by Dr. Daniel. He's been talking about the importance of the health force worker in the present and the future, and how important to invest in the health force itself. Now, let's continue to the third speaker, Dr. Hirotsugu Aiga. Dr. Hirotsugu Aiga graduated from Waseda University in 1983 and became a research fellow with World Health Organization. Dr. Hirotsugu Aiga is the Senior Advisor on Health, Nutrition, Japan International Cooperation Agency, in short, JICA. Dr. Hirotsugu Aiga is a specialist in the field of human resource for health, health survey, health information systems, epidemiology of infectious disease, household food security, and resource mobilization with lifelong international experience. Dr. Hirotsugu Aiga is going to talk about need for adapting health workforce density threshold to new WHO ANC guideline based on his recent short publication on the Lancet Journal. Please give a warm welcome to Dr. Hirotsugu Aiga.
Thank you very much for introducing me. My name is Hirotsugu. I am Senior Advisor of Health and Nutrition JICA. I just highlight on the human resource of health in the context of developing country, because I'm working for developing agency. I'm not very special the HRH in the context of developed country like Japan. This is a photo I have taken just 2 weeks ago. I was in Burundi in January 2020. And let me begin by talking about her. My presentation is composed of 3 parts, but maybe most likely I will skip part 2 because of time limitation. I just want to focus on this one key issue. Again, this photo, she is 20-year experienced MCH nurse working at the Rural Health Center in Tega province of Burundi. We are waiting for her at 7:30 a.m. Next to this consultation room, there is a waiting room. There are 38 pregnant women mothers waiting for her. And outside of this waiting room, there is a corridor. 24 pregnant women mothers follow them. So this is structure of the health center building. 1 pregnant woman in consultation room, 38 in waiting room, 24 on corridor. In total, 63 pregnant women mothers are waiting for just 1 NC. this is the situation, unfortunately. But this is unfortunately also very common in Africa, maybe some parts of Asia as well. WHO defines the anti-infective care, minimum number of anti-infective care contracts for contact is minimum number of anti-infective care contracts in 2002. And in 2016, the WHO revised it, redefined 8 as a minimum number of anti-infective contracts. This means greater number of visits to be made by pregnant women. If the number is raised from 4 to 8 in terms of the minimum number of anti-infective care contacts, how much more congested will waiting be? How much longer will pregnant woman and mother have to wait? How well will the factor center keep functioning? And most importantly, how much easier the nurse be? This is a key question in the context of health workforce. There are 25 early adopting countries of the new anti-infective care guidelines of WHO, which increased from 4 to 8. 21 African countries and 4 Asian countries. They are in the process of revising national ANC guidelines. They try to raise from 4 to 8. The question is that, do we have an adequate number of health workers to enable local health systems to provide every pregnant woman with 8 anti-infective care services? Looking at the health workforce density thresholds defined by WHO in 2006 in WHR, it defines as 2.28 health workers, physicians, nurses, midwives per 1,000 population. In 2016, in the global strategies, they redefined 4.45. The 2.28 was based on the it was designed so as to ensure the 80% of skilled birth attendants. On the other hand, 4.45 was defined or designed so as to ensure the 25% percentile of composite index of 12 SDG indicators. So what are the 12 SDG indicators embedded to 4.45? Skilled birth attendants continues to be part of that, but we added 4 or more anti-infective contacts, and then maybe 10 other elements are added. The issue is 4 anti-infective contacts. That's been again increased to 4, 8 or more anti-infective contacts in recent WHO guidelines. So this is the key numbers. Ensuring 4 or more anti-infective contacts is one of the 12 elements of 4.45 health worker per 1,000 population. But according to WHO's new guidance on anti-infective care, they recommend 8 anti-infective care contacts, not 4 any longer. The 25 countries are already started raising, and many other countries will follow. So definitely, we expect WHO to increase. This is not criticism WHO, we just request WHO to try to consider the further revise, maybe probably increase from 4.45 to maybe around 5 or 6. I don't know how to calculate because it's very complicated. In the context of Burundi, for instance, unfortunately they have only 0.73 health workers per 1,000 people. In the current WHO threshold 4.45, there's a huge gap. I calculated quickly, and then additional 40,000 health workers will be necessary. But if WHO further increase by revising, by considering the increase in minimum number of anti-infective care contacts from 4 to 8, maybe definitely to increase. Maybe additional, maybe X number of people, X number of health workers will be necessary. Gap is huge, so we have to invest more in the health workforce. This last kind of interesting slide. And new WHO and anti-bacterial guidelines says 8 or more, but it's published in 2016. In the same year, 2016, global strategy was published. That was based on 4 or more anti-bacterial constants. So maybe there should be more consistency between 2 guidelines of national and international standards. Of course, I know there's some difficulty, but that is something I would provide. Maybe I'll skip these JICA supporting area of HRH because of time limitation. Just final conclusion is that I sincerely request WHO to further revise the health workforce density threshold, include in response to the change in minimum requirement, minimum number of anti-bacterial contracts from 4 to 8. Second, for myself, for ourselves, like JICA. JICA has health department, education department, labor, also industry department. We have all department in one organization. So by leveraging that kind of situation of my organization, maybe JICA should address HIT in more comprehensive manner, not only looking at the health aspect, but also even the labor force marketing, also economic impact, and also for the education sector. Currently, we just look at from health side. That is a kind of frustration I have for my organization. Thank you very much.
Thank you so much, Dr. Hirotsugu, for an insightful presentation about how important of the workforce density relate to the new WHO ANC guideline. Now is the time that everybody is waiting, the time for Q&A session. So let's start from any question from the floor. I will go around looking for questions. Is that all right?
Comment of insights or your perspective.
Please feel free to raise your hand, and then our MC will deliver you the microphone.
Hi, Mike Lin. I run an IT social enterprise in Myanmar. I guess 2 questions. I mean, one, usually a lot of these governments, like Myanmar's, are extremely budget constrained, right? I mean, tax receipts are really low. So, what's the practical reality of allocating more government funding to hire more and train more health workers, right? And then sort of 2, is there, I guess related to all of this, is there any research showing that where automation or digital technologies, while being not a substitute, but can, be a complement to handle this bandwidth problem where you simply don't have enough human health workers, right? So for example, telemedicine, are there any RCTs or impact evaluations, or is it really, so far, digital technologies have been ineffective in helping bridge this gap?
Thank you for the question.
On the cost of health services, there was a presentation from Mexico at the aging session yesterday where they contrasted Mexico's health expenditure with the US. So there's only a 2-year difference in life expectancy between Mexico and the United States, and yet the US spends 20 times more per person than Mexico. So you can achieve a huge amount without necessarily spending massive amounts of money. It's a question of how efficiently and effectively you spend your money. So I don't, and the point I made about the medicalisation of death, we do need to have a conversation with our populations on what their expectations of health and care should be. And before, when we're getting an ageing population, we need to be constantly dialoguing with the communities, engaging them in discussions about what are the priorities, where should the priority investments be, informed by evidence of what works and the opportunity costs of different forms of investment. So you do need digital communication, you do need to try to innovate using other ways of reaching people without necessarily escalating expenditure. But I don't think anybody has the solutions, but I do think collectively we can share information on different approaches and learn from one another, which is why these fora are so important. But we need to establish electronic platforms to some extent to enable that learning to happen across the world so that we can benefit from the innovation, and particularly frugal innovation, in terms of understanding what can be done well for the best price.
Maybe just to address your first point, I mean, I think maybe 3 points on your first point is one, I think there's general consensus, and I think all of us who work in the health sector see it. There's a lot of waste in the health sector, and I think we need to make our health systems more efficient. We need to, they say that there's 20 to 40% of investment in the health sector is wasted or could be made more efficient. So I think that also, any economies we can make, any savings we can make by making our health systems more efficient will benefit the health workforce. I think the second thing is I think we need to be looking at innovative financing mechanisms for health systems and health workforce. We have a lot of innovative financing mechanisms for health promotion. Why not channel some of that funding to investments in the health sector, in health workforce? I think that's also important. And I think finally, and maybe the point I was trying to make is that, yeah, sure, there's not enough money, but we need to be making strong policy arguments and a lot of advocacy to not only health ministers, but to finance ministers and to heads of state saying, look, investing in the health workforce is not a burden. It is going to drive economic growth. It's going to improve GDP. You're going to get a huge return on investment for investment in the health sector. So we need to start thinking about changing people's mentalities, transforming people's preconceived notions and dogmas about investing in the health sector, and especially in the health workforce.
Any other?
Okay, thank you. I'm totally agree with Daniel's views, particularly in terms of the impact or return, like the return of the investment in health workforce will be big. Maybe somebody, economist like Professor Stiglitz also, they maybe calculate that kind of impact. From my point of view, from the development agency point of view, I would, actually we are internally discussing among colleagues in JICA that we're going to provide kind of generate budgetary support in the loan project, big loan project. Sometimes recently $100 million to Rwanda and similar to other countries, not only Asia, but also we are moving to the Africa. It's a general budgetary support, but we have specific kind of conditions, what we call policy matrix. We have specific policy milestones, and if they achieve this policy, then now we disburse money, something like that. And then we do use a kind of use this kind of loan program or loan project for guiding government to change their policy. And then we are currently considering the inclusion of bigger and greater investment as workforce as one of the key policy that should be a kind of condition for the next disbursement also. So that's something we are doing. So we haven't started yet, we just started considering, but we have done similar thing for the nutrition and food security. So if they develop specific policy on the nutrition or food security, and they actually implement it, we disperse money for any use. So that is the kind of what we can do from JICA.
Very good comments. I just want to bring to mind one example. So in Myanmar public hospitals, from any size, there are only 2 inventory turns per year, meaning new medication, new equipment is only restocked twice a year. So I've walked into head medical store of the central medical store, maybe I think the largest hospital in Myanmar, and a third, the specialists there estimate a third to half of all the medications have expired. I mean, that's like an example of how inefficient it is, and it's largely due to the government procurement process being so complicated and like Kafkaesque, that by the time a new procurement order has been approved by 20 people, you know, you've had this huge, and that's national, right? So, and there's no supply-demand matching, so there's a secondary market of doctors who work there who really care about treating patients and administering, you know, the medications they need. They have to buy out of their own pockets secondhand from private pharmaceutical providers. I mean, it's just like the scope of the problem is so enormous, and where, you know, I agree, just there seem to be like a million things that need to be improved in terms of efficiency.
Just one quick comment on that. There are so many problems in the health sector, it would be easy for us to focus on just solving those. But one of the points made in the health promotion sector yesterday was that we don't just need to focus on reforming the health services, which are incredibly expensive. If we want to really deal with the problems of promoting health and prolonging life, we need to think outside of the health sector and healthy public policy, preventing diabetes. I mean, Mexico, 20% of the population are diabetic, and unless we tackle obesity and some of the public health problems through other interventions, then we're just building problems that no matter how much we increase the efficiency of our health services, we won't solve. So we're not spending nearly enough on health promotion and disease prevention as we need to rethink the balance of our investments as well as solving very practical problems of the health services.
Just a quick comment in response to your question about digital health. I thought that was a very good point raised. I'm going to briefly talk about that later as well. And you asked about whether there are evaluations on whether digital health interventions have been proving effective in addressing all these issues. And you raised an example of telemedicine. And to my knowledge, there is no systematic review on telemedicine yet, but there are a lot of RCTs showing that telemedicine is either proven to be very cost effective or not inferior to outpatient. And there are a lot of different assessment frameworks out there, which is one thing that we need to work on, how to evaluate digital health interventions. That is a good point that you raised about other ways to really address this issue of lack of workforce and resources.
Thank you. Being from Myanmar, I'm Dr. Gilati, previously from the Ministry of Health, retired 7 years back, but I'm working for the Human Resources for Health. So the discussions that have just made, Myanmar health system is like, you see, when the WHO benchmark was like 2.28 per thousand health workers, we were having 1.14 only. And then there was not much improved in the health workforce. And when you show us about this applicant, the same is happening in the country, but for the service readiness, even we are going for the UHC with the new national health plan, but like all the systems we are feeling is not ready yet. Talking only about health workforce, we are working on also on the retention of health workforce. How we can retain these people in the in the rural and remote areas, because all these people who are in the rural and remote areas have to rely on these health workers who are there. That's one thing, but the things that we cannot do as yet is that there is no such support for them to stay there. So that is what we are trying to do it. And then in the, in the system development, we still have so many, when we are talking about quality, we have trying for the access only. You see, and then this is from the service readiness side, but also from the community side, we have to think about that. So a lot need to be going on, you see. But this telemedicine and things have been done by the private sectors nowadays. So everybody, when we are talking about the primary healthcare level, it is on the public sector's shoulders, but a lot of things has been done by the CSOs as well as by the communities. So that is how Myanmar is trying to fight.
Thank you very much for your comment. So how much do we have for the time?
Almost time up.
Almost time up. So let's continue to our next session. Thank you for every comment and every question.
Just a quick reminder, we are going to have another discussion time. So if you have any question or if you want to raise any more question, you can note it down, and then we are going to open the floor for the question and also discussion later in the second section on this conference. So now we already have reached half of the speaker list. So please let me welcome the fourth speaker, Professor Dr. Wanicha Chuenkongkaew from Siriraj Hospital, Mahidol University, and Secretary General of National Health Professional Education Foundation. Professor Dr. Wanicha qualified in medicine in 1986 after residency at Mahidol University. As an ophthalmologist, she completed a fellowship in neuro-ophthalmology at the University of Michigan Medical Center, United States of America. She was appointed as a professor of ophthalmology at Mahidol University and is internationally recognized in her field. Professor Dr. Wanicha is a vice president for education, Mahidol University, and also a coordinator in organizing the annual Prince Mahidol Award since 2007, aiming at being a global policy forum to discuss and recommend policies and social commitments toward education in Thailand for many years. Professor Dr. Wanicha will give the speech about the sharing of Thailand's movement on development of health workforce and health professional education. Please welcome.
I'd like to share our Thai context on investing on health workforce. Right now, currently in Thailand, experience among the most rapid rates of population aging in developing countries. So Thailand will approach complete aging society by 2021 and super age society in the next 10 is a decade. This implies that the country will face emerging issues related to social security, healthcare costs, and intergeneration equity in a far shorter time span. The increased number of disabled and underprivileged homebound and bedbound persons in Thailand. At present, less than 4,000 older persons are institutionalized for long-term care. This is very important issue. I think challenges for health workforce in developing world is the same because we have the shortage of well-equipped health workforce. So in Thailand, apart from the aging society, elderly are vulnerable to the risk factor contributing to non-communicable disease. Dependency and major depressive disorder could impact countries' economy in 2013, and NCD on non-communicable disease accounted for an estimated of 280 billion baht, about 10-15 billion USD of Thailand economic burdens. And also what we work in our country, this is the new and innovation for investing health workforce in Thailand, people-public private partnership for peace. We include people and also public-private together. This is the innovation, but they have already implemented in Thailand in community hospital for a long time. So this is the conceptual framework. We have three partnership for private with one. The community and the government, the community, the government and the private practice. The community is the people. That's for people. The community means the people who work in those areas, not for the health sector only, for non-health sector as well, and for private sector, we include the company mostly for social CSR, corporate social responsibility, and for government is the community hospital mostly. For those partnership, we arrange this project, the developing of guideline model for appropriate partnership among community and local people, government agencies and private sector, people, public, private partnership in health system management and primary health care. The three objectives. The first one is to study the situation on PPP, people-public-private partnership for knowledge generation. And the second objective is to analyze the appropriate innovation of OP on primary health care services and management. For the third objective is to develop guidelines for evidence-based policy development. We include three methods. We use the questionnaire in-depth. We develop questionnaire in-depth interview and focus group discussion. We recruit sample size from those outstanding community hospital. Right now we start with all over the country with 4 regions. Northern east part in Ubon Rat and Naphong at Khon Kaen province, and Langu in the southern part, and in the central part at Tha Vung, and also Majan in the northern part, and also Saraburi is the central part of Thailand. Those are the model that we try to analyze. The model of the investment is come from the Thai Constitution for to invest on primary health care in Thailand. And now Thailand is now an upper middle income country. So right now we invest on the community hospital. We have the law for disability. We have the disability and connect link to the company for CSR or corporate social responsibility. They can hire disabled people to work in those hospitals or any local government, and they can pay for those disabled. So those health workers, instead of work in the private company, they can work anywhere all over the country, and this reduce the challenges on shortage of health workforce in our country. So those disabled, the community of the disabled, they can be trained to be a health workforce, to work in the hospital, and also they can work either on social enterprise. Some challenges is in Khon Kaen. This we include people who work in the community. They can share, they can donate their income for about 1,000 baht or only 30 USD per month, not per month, per year. And they after they donate for 30 baht per year, when they get sick, they can be admitted at the hospital for free of charge. This is the cooperation between people in the community and also the private sector to invest on the workforce, and this reduce the challenges of shortage of the workforce in many communities. And this is going to be extended to other community hospitals in Thailand. And those will